Okay, good afternoon. I hope this technology works okay and you can hear me. Since I'm traveling this week for the session on February 8th, I wanted to actually do this video or attempt to do it because I thought that some of this material is important and I wanted to ensure there's some continuity in the class. So what I do want to do is start just very quickly reviewing a few of the things that we started to talk about in the last session and then move forward with what we refer to as critical medical anthropology and structural violence, kind of talk about what that means when we talk about structural violence, for example. So last time we had addressed the issue of explanatory models of illness. We had talked about this concept in medical anthropology and explained that it's partly derived from psychological approaches to schema that we have in our minds that are culturally learned about how to behave in particular scenarios. And medical anthropologists have borrowed this concept and used it to talk about how we learn culturally within our respective societies about how to address the 5 different elements that explanatory models of illness tend to address, which is the etiology, pathophysiology, diagnosis, and treatment of an illness event. I think a lot of this is review, but we had made comparisons to, for example, diagnostic categories like mal de ojo or the evil eye, and asked the question of what happens in a pluralistic medical setting. So one in which there's multiple explanatory models that might be competing because there's different kinds of cultural backgrounds that are combined in a pluralistic or cosmopolitan environment, which a lot of us live in. In an event like that, where would people go first in a hierarchy of resort approach? So people would tend to, if they're diagnosed with mal de ojo, they're not likely to go to Western biomedicine and report that concern. They would go to a local healer or some sort of practitioner that is culturally understandable within their context. I think that's obvious perhaps, but what we're trying to do is to say that we exist in pluralistic medical settings that have competing and sometimes you might say contradictory medical systems in which people are navigating, and they navigate through those in somewhat complex ways. Drawing on that or moving a little bit further with that idea, non-Western local ethnomedical systems often are the initial default for illness management. I think we had mentioned that last time, that in many parts of the world, often people are starting with local ethnomedical responses to an illness event. Medical anthropologists have also sort of then looked at how it's culturally defined to navigate oneself through a complex hierarchy of resort in the event of an illness event, and talked about therapy management groups, which are culturally defined individuals that are supposed to be in charge of managing an illness event for a family structure, for example, or for a community, depending on the context. So this management group is also culturally defined by issues such as gender and age. So for example, it may be appropriate in many societies for a husband or for a male member of the family to make particular decisions, even when it involves women's personal health decisions. And in those cases, we would say that the therapy management group is culturally defined by particular dynamics of gender that are important to understand in that context. So Western medicine has often sought for certain ailments, but less so when diagnosis and treatment are unclear or ineffective. So that's another interesting point, that maybe some of this is commonsensical if you think through it, examples, but when you're unable to get a clear diagnosis, or when Western biomedicine is less capable of treating something that you perceive as an illness, people also are much more likely to go outside of Western biomedicine to seek some sort of cure in those kinds of cases. So explanatory models may be diametrically opposed, as we mentioned, in pluralistic contexts. One example that is sometimes raised is the contrast between the use of the flu in the West, the idea of the flu, which some anthropologists have analyzed as the folk flu, because it contradicts with how epidemiologists tend to understand the flu in many cases. The symptomology of what we culturally often describe as the flu, for example, when people are referring to the stomach flu, contradicts with the ways that epidemiologists who are trained to understand the flu according to particular categories of disease simply don't understand, or just those two approaches simply don't mesh with one another. So that can also contribute in some cases to issues of misdiagnosis, mismanagement, or failure of epidemiological surveillance. In cases where you have these conflicting models that are at work in a pluralistic environment. So, and some lay models may also function to manage stigma of more severe or socially unacceptable illnesses. So this is another thing that sometimes medical anthropologists have talked about, that the ways that non-Western diagnostic categories allow people to label themselves in particular ways that allow them to sidestep to some degree the social stigma that can come with certain categories like HIV/AIDS, cancer, other kinds of clinical diagnoses. So if you have something that is available to you as a category to explain it, such as possession, or someone cast a spell on me, or it was a sorcerer, those kinds of explanations, which do exist more often than one would imagine. Those offer alternative explanations for people to manage the stigma that might be associated with alternative definitions. So just as one example of that I think is an eloquent example of the conflicts of explanatory models of illness in pluralistic environments, there's this book called The Spirit Catches You and You Fall Down. I think the author is Anne Fadiman. And she takes a very ethnographic or very anthropological approach to looking at what happened in the case of a specific Chinese Hmong immigrant child who I think is around 5 years old during most of the book, how she ends up falling through the cracks and dying as a result of very treatable epileptic condition that she had. But that because there were such very different explanations and explanatory models being used to understand what was wrong with this girl, she simply fell through the cracks. The Western doctors were unable to communicate with the immigrant family, and vice versa. The family was unable to really understand or assimilate the different kinds of information that they were receiving about the girl's condition, and then the girl ends up tragically passing away as a result of that conflict of explanatory models. So that is review, and at this point I'm going to pause the recording to make sure that we are technically sound, and then I'll move on with introducing critical medical anthropology.